Welcome to Digital Health Week 2026. I am Kit Huckvale. I'm the Acting Director of the Centre for Digital Transformation of Health. And as we start, I would like to acknowledge the traditional owners of the land, the Wurundjeri Woi Wurrung people, the traditional owners, and I'd like to pay my respects to elders past, present and emerging. We recognise the unique place held by Aboriginal and Torres Strait Islanders peoples as the original custodians of the lands on which we are meeting here today, with a history of continuous connection to the land dating back over 60,000 years. The first technologies used in Australia were those created and applied by Indigenous peoples, and as a community of researchers, innovators, teachers, professionals and healthcare staff working now with the latest technologies, we are privileged to work and learn every day with Indigenous colleagues and partners. So welcome formally to Digital Health Week 2026. We are bringing together a huge crowd of different people, researchers, practitioners, innovators, technologists, emerging leaders in digital health for a fast-paced morning. We're going to share ideas. Hopefully you'll get a chance to connect. You'll hear the latest ideas and start hopefully to foster collaborations that will continue well beyond this week. This is a grassroots event. We want you to be here, be present, get involved. It's running across Melbourne, Sydney and Brisbane, and our shared aim is to showcase up-and-coming researchers, people who are shaping the future very literally through their work and ideas, and broaden your exposure and our shared exposure to ideas and diverse work that's happening in this exciting space. So we at the Centre for Digital Transformation of Health are very proud to be hosting this event. We are a group of researchers, clinicians, practitioners and innovators who are working to really realize the power of data, of AI and of technology to transform health. And our vision is to see the healthcare system transformed for good. What if we could learn from every patient to improve care? What if we could make sure that every new digital technology is always safe, is always equitable and always effective? And what if we could give the workforce the skills, but also the bandwidth and support needed to drive change involving data and technology? We bring this to life in two ways, through hands-on support, which we offer through our research platform, and through education. Our research platform, the Validitron, collaborates with researchers, industry and people working in healthcare, people like you, to accelerate the integration of promising digital technologies into routine clinical practice. And it comprises translational scientists, research methods. We do a lot of work with clinical simulation and technologies. And our team aims to bring the right expertise to bear to assist digital health initiatives, whether it's through clinical simulation, through consumer engagement, through co-design, machine learning and AI, data analytics, implementation science, economics and evaluation. So whether you need advice or wayfinding or just hands-on help with your project, we're here to help, and please do get in touch. And if you're excited about design thinking, about user-centered design, about implementation science and evaluation in digital health and the challenges of making that work, we'd love to connect with you. We also provide practical, tailored and high-quality education for people who are passionate about the potential of digital health. Our programs are designed to help you gain the knowledge and the confidence to safely and effectively lead change, to be the change makers in health, whether that's involving data or AI or technology. So if you want to build your career with practical skills in this area, if you're interested in using data to solve real world problems, if you want to understand what data AI is really about and cut through the hype, then I think our programs might have something for you. And our approach is very much designed to flex to meet you where you're at. So we have short courses, we offer one-off masterclasses, micro-learnings and self-paced online learning. And so if any of that has piqued your interest, please do sign up to our newsletter or talk to one of the team in the break. We'd be delighted to connect with you. So let's get back to the main event, Digital Health Week. Firstly, I want to say a big thanks to the University of Sydney's Digital Health and Informatics Network, who took the lead in pulling this event together, working in partnership with us at the University of Melbourne, the University of Sydney and the University of Queensland. We're excited for today's program here in Melbourne. We obviously have the best audience here in Melbourne. We hope to match that with a really high quality program of events spanning the breadth of innovation topics, such as developing dashboards to improve pharmacy care, all the way through to social media initiatives that are aiming to empower young people in this space. And we're particularly excited for the keynote, which will be coming up shortly. It falls to me to do a little bit of housekeeping. So toilets are in the corridor outside this lecture theatre, just down and to the left. If you need water, there is a kitchenette just beyond the toilets. We will be taking photographs throughout this event through the morning. And if you prefer not to have your photograph used, please just talk to one of our staff. There will be a light tea, morning refreshment, very kindly provided through the support of the CRC. If you need barista coffee, then Dr. Dax is just out on the parade. And there are going to be two streams this morning of research presentations. So stream 1 will stay here in the lecture theatre. Stream 2 will be in the beehive space, which is just out on the right on the way to the kitchenette. And in each room, there will be 2 blocks of presentations with a break. So you get a chance to mix and match, and feel free to move between the spaces. But to avoid disruption, we'd like to ask you to stay in a session until there is a break if you want to move. We also have an evaluation survey. We are researchers after all, and we will share that at the end of the streams. And incredibly grateful if you fill it out. It does help us tailor and improve our event. So now I would like, and I'm delighted to be able to introduce Dr. Claire Morgan, who is the Deputy CEO and Director of Research at the Digital Health CRC. The CRC are our generous sponsors for this event. The catering and support for running this wouldn't have been possible without them. The CRC connects research, industry and government to share and turn digital health research into practical solutions with a focus on improving care, supporting healthcare workers and helping people take control of their health and well-being. Claire, welcome to the stage and thank you for opening this event.
Good morning. I'd like to begin by also acknowledging the Wurundjeri people of the Kulin Nation as the traditional owners of the unceded land that we're meeting on, and pay my respects to their elders past, present and emerging, and also acknowledge and extend that respect to any Aboriginal and Torres Strait Islander people here today. So it's a real pleasure to be here to welcome you to Digital Health Week 2026, a week that is in one day in Melbourne. So with its focus on collaboration and grassroots research, Digital Health Week occupies a unique place in the digital health events calendar and has become an especially, as Kit said, important opportunity for HDR students and early career researchers to showcase their work. It's gone from strength to strength in its short history, and today's event promises to be one of the best yet. So the digital health sector is evolving at an extraordinary pace. New technologies, more and more data, and new models of care are emerging every day. But with that pace comes complexity in the form of technical, ethical, regulatory, and human challenges. And research plays a critical role in understanding and addressing these challenges. It gives us the assurance and the evidence and ensures innovation is safe, effective, and genuinely impactful. So the first thing that came to my mind when I considered this year's theme of digital futures, rethinking health and care, was the recent launch of ChatGPT Health only a month ago. And with that, the US government's recent push for an innovation first, regulation second approach to accelerating the adoption of AI in healthcare. So we're at a pivotal moment in history where digital innovation must be translated into safe, equitable, and sustainable models of care. The catch cry in recent years has been the future of health is digital, but the future is now, and rethinking is no longer optional. It's essential for shaping a connected, resilient, and human-centred health future. So at the Digital Health CRC, we see every day how research designed for real-world implementation can influence policy, strengthen capability, unlock the value of health data, and support safer, more equitable care. And as is the case globally, we know that innovation is really the barrier in Australia. The barrier is implementation. And implementation depends on evidence, governance, assurance, and the right skills and partnerships. It's founded in co-design and a deep understanding of evidence-based best practice. So today's program invites us to consider not just what's technically possible, but what's meaningful, responsible, and transformative for patients, healthcare providers, and the community generally. How can we use data and digital technology to move the needle when it comes to the quintuple aim? Today is also about showcasing the depth of digital health research happening here in Victoria. Across the streams, we're going to hear work spanning social impacts, equity, governance, wearables, AI-enabled tools, cybersecurity and co-design. It all reflects the richness and diversity of the local digital health ecosystem. So for me personally, it's good to be back in Parkville today. I'm actually from Perth. I did my PhD there, but I moved to Melbourne about 17 years ago to start my own early career research journey just over the road at Weehai. And I want to speak briefly to the PhD candidates and early career researchers here today. So I've sat where you're sitting. You're probably dying of nerves. I know I was. I remember the first time I got up to speak at an institute seminar, I felt like I was being strangled. But I also hope that like me, you're being fueled by curiosity and caffeine to navigate messy data sets, to revise your hypothesis, second guess your research. And maybe like me, you're wondering whether your work really matters outside of your thesis, outside of your own lab books, or maybe your first papers. So the DHCRC is supporting this event because we know your work does matter. This is a time where the value of rigorous research is under threat, and your work forms part of a much larger story about strengthening Australia's capability in digital health. So, innovation is global, but health is personal, individual, and local. And we need Australian researchers to focus on digital health to ensure that digital health technologies are appropriate for the Australian context and safe and effective and for the benefit of all Australians. I also want to remind you that impact rarely arrives quickly or in a straight line. Sometimes it takes years. I definitely know that. And it can become visible in a variety of ways, through a policy shift, making a technology be adopted more safely, a workforce that feels more capable, or a community that experiences care differently. And sometimes it comes in ways that you don't expect. Just an incidental conversation that can open a door, reframe a question, or spark a collaboration that changes your trajectory entirely. And that spark could happen today. So our roles as researchers are critical. The sector needs our ability to think deeply, challenge assumptions, and navigate the tension between innovation and responsibility. It needs courage to ask the harder questions and a willingness to pursue the evidence when it complicates the narrative. And so to everyone in the room, supervisors, clinicians, policymakers, executives, your role in supporting emerging tech researchers is just as important. Creating pathways from research to impact requires mentorship, collaboration, and trust. When we invest in researchers early, we strengthen the entire digital health ecosystem. So I'm really excited by what is being presented today, but I'm just as excited by what it represents. It's a sector driven by evidence, powered by innovation, and a collective commitment to designing a healthier future. So I'm also very excited and really looking forward to hearing from our keynote speaker. But first, I've just been asked to run through today's proceedings. So we'll have this session now, and then morning tea, which will go until 10:15. And then, as Kit mentioned, there'll be 2 concurrent sessions to showcase 20 talks from researchers across the sector. So myself and our keynote speaker, Professor Peter Steele, will be chairing and judging Stream 1, and that'll focus on technical and design. And then in the beehive, we have Carol Kenny-Sarasa from AIDH and Belinda Davey from the Centre for Digital Transformation of Health, who'll be chairing and judging Stream 2. So they're going to be fast-paced presentations, about 7 minutes long. Here, some of them will be in the Pecha Kucha style, And then there'll be a Q&A with 2 winners from each stream to be announced at 1:30 during lunch. So with that all out of the way, it's now my very great pleasure to introduce today's keynote speaker, Professor Peter Steele. Professor Steele is a leader in digital health innovation and quality improvement science. His work focuses on translating data, AI, and digital health innovation into practical, scalable impact through learning health system approaches. Previously at New York Presbyterian and Weill Cornell Medicine, he led federally and industry-funded research on AI-enabled care transitions and implementations at scale. He serves as Vice Chair of Quality Improvement and Patient Safety for the American College of Emergency Physicians and advises health technology companies on responsible innovation and academic partnership. We're delighted to have him here helping the local ecosystem. Please join me in welcoming Professor Steele, who will be speaking about learning health system strategies in the AI era.
Thank you for the warm welcome. And please tell me if I need to speak up. I would also like to acknowledge the traditional owners, the unceded land on which we work, learn and live, who are the Wurundjeri people of the Kulin Nation. I pay my respects to elders past, present and emerging. And as Kit mentioned, it's also important to note during Australia's Digital Health Week that the first technologies used here were those created by Indigenous peoples. So whether we knew it or not, as we work and learn and study, we're standing on the shoulders of giants. Before I arrived in this beautiful city, my last study in the US was a usability assessment of an exciting new AI technology. 2 deep learning AI models were built to detect the tiny pulsatile capillary color and movements of the human skin through a conventional cell phone camera. In controlled settings, the model transforms those measurements into readings equivalent to medical grade blood pressure cuffs, substantially more accurate than the type of blood pressure monitors typically bought for home use. Imagine the ability to monitor women at risk for preeclampsia in remote rural environments through a mobile phone. If we demonstrate real-world generalizability and feasibility, it will become a hyper-scalable, transformative technology. But using the next 45 minutes to talk about the cool stuff I did and framing it within the learning health system, while fun for me, I think would perhaps not be what this group needs. We want to discuss the complex problems we will collectively need to navigate, particularly within health services and hospitals, if we are to realize the potential of AI. Sorry. So in the early 2010s, a simple question resonated with many, both inside of healthcare and in other technology-driven industries. Why were we, in the era of the EMRs and vast amounts of digital health data, failing to leverage that data to continuously identify opportunities and improve performance? Enter the learning health system, endorsed by the Australian government's Department of Health, the US National Academy of Medicine, and the World Health Organization. This is the central vision. Data is routinely generated during the patient's care journey, often in the EMRs or other digital systems. Informatics teams then clean, label, and harmonize the data so it can be easily analyzed. That analysis allows us to gain new knowledge, for example, exploring post-op complication rates across a series of orthopedic surgeons, or comparing the use of 2 medications with similar efficacy but different costs. And informed by that knowledge, multidisciplinary care teams, researchers, clinicians, operational leaders, and patients can collaboratively optimize or redesign clinical care or operational processes. Using the 2 examples, perhaps developing targeted retraining for surgeons with high complication rates or clinical decision support to prompt clinicians to prescribe the equivalent but cheaper medication. And then implement those innovations. The learning health system cycle is closed by the measurement of the impact. And that measurement could be patient outcomes or experience, greater operational efficiency, or even cost. Critically, impact measurement is again achieved by using the data automatically generated by the patient's care journey. This is an opportunity for a virtuous feedback loop of learning, integrating high-quality data and biomedical informatics teams, as well as multidisciplinary care teams and researchers. This drives the continuous refinement society reasonably expects from healthcare, rigorously and rapidly testing what works in real-world settings, pivoting designs when no impact is measured, generating knowledge that informs us to only scale what demonstrates measurable value. Employing this rapid cycle approach, the argument goes, is both a lower cost proposition than traditional research and a faster path for healthcare to innovate. Now, some of you may be thinking, this just sounds like really solid health services or translational research. But the learning health system is not just a description of the science that can be achieved and accelerated within. Translational and clinical research are products of the learning health system. It's very important to appreciate the scale here. This is not a cycle to support a one-time quality improvement project or a research project. This is a system-level process of continuous improvement and innovation, happening across many different areas of the organization simultaneously. It is a vision of a complex, adaptive operating system for a hospital, a local health service network, or even an entire country's public health system, requiring motivated actors with the right capabilities, capacities, and incentives. Part of this misframing, I think, around research is because as the learning health system gained momentum, it was strongly advocated for by the research community. And who could blame them? The value proposition to researchers is huge. The resources it takes and the cost to perform high-quality translational and clinical research often makes the science too slow or too costly to engage the fast-moving operators within a health system. This is one of the primary reasons for the well-described translational valley of death, this disconnection between ever-increasing biomedical research in this ecosystem of world-class research and routine care delivery, which for patients, unfortunately, do not always benefit from that research. So we could probably spend half the day examining in detail the important learning health system constructs that academics, probably like me, have developed in all its socio-technical complexity. And we could spend the other half of the day discussing why, despite the near unanimous international endorsement of this model, even incredibly well-resourced and engaged health services have not been able to fully manifest it. We should perhaps briefly review some of the important historical challenges, though, for context. A learning health system functions only when its core verticals are aligned and intentionally integrated around shared clinical priorities. Ideally, each domain would play a distinct but interdependent role in the learning cycle. But in reality, our industry has developed long-standing verticals over decades, often with their own data, their own culture, their own priorities and incentives. And many of those verticals have deliverables under time pressure, which don't always map well on traditional research timelines, which helps us understand one of the main reasons we can't simply just switch on the LHS. I said this knowing only too well how challenging these goals are, but some crude guiding principles to the learning health system include integration of traditional verticals, research, speed up a little, hospital operations, slow down. Conway's law argues that organizations are always doomed to build systems in the shape of communication silos, which helps us understand another big challenge preventing them from flipping the learning health system switch: the complexity and fragmentation of patient data within most health systems. I'm confident we can all agree on data's importance as a strategic asset in healthcare, particularly in the learning health system model. Foundational data infrastructure should translate to improved outcomes, no? And it can achieve this through facilitating the measurement of the current care models and patient outcomes, informing the design of interventions, and then measuring outcomes of those interventions. But historically, just as Conway's rule predicted, health data has been siloed across clinical, operations, business, and research domains. Modern healthcare systems must manage complex data flows that bring together data from a wide variety of numerous sources: EMRs, clinical registries, lab results, radiology results, even genomics, and non-clinical data, administrative systems, billings, claims, scheduling, and so on. The huge challenge is to ingest all that information, clean it, harmonize it, ontologically label it so it has clearly understood reproducible meaning, store it securely, ideally in a centralized data warehouse, all while maintaining patient privacy. So we're going to revisit the value of data investments later, but the important point is this remains an ongoing major challenge for most organizations. Now, my interpretation of this learning health system history is despite all the challenges I just mentioned and others, even very well-resourced academic health systems with research and quality improvement as central missions have been facing even bigger challenges of increasing demand and narrowing margins for a multitude of reasons. And it's those realities that left the inspiring learning health system operating model with its many potential benefits relegated to perhaps nice to have, not need to have. Because of those constraints, for organizations who have remained engaged in the LHS model, it's become a sort of aspirational North Star. Rather than a binary, we either are or are not a learning health system, the posture has become more, we're on a learning health system journey. And that journey's path has been to systematically identify the friction points and underdeveloped socio-technical elements in each organization, and slowly find budget-friendly opportunities to improve the speed with which we can learn, innovate, and adapt with insights from clinical data. Now, I love architecture, so humor me this analogy. The house of medicine, perhaps more specifically hospitals and health systems, were developed over the past century to hold their intelligence, for the most part, in their people, not in their structure. So it was perhaps unreasonable over the past decade to expect this pretty functional mid-century house to suddenly be updated into a fully integrated, digitally agile operating system. Okay, so let's put all that in a box. That's Learning Health System 1.0. Inspiring, I hope. Nice to have. But unfortunately, healthcare didn't experience like a full strategic reset or a huge capital injection. So it hasn't fully manifested. But many people continue to advance the agenda, both with promoting local achievement at a meso level and continued thought leadership at a macro. It was interesting to listen to the speakers at Davos this year. There were really only two subjects at play: AI and Donald Trump. Worldwide AI spending totaled 1.5 trillion in 2025. Current global market evaluation for healthcare AI is 30 to 40 billion, estimated to grow to over 600 billion by 2030. But irrespective of all this spending, AI is yet to declare victory in transforming any industry, especially one as high risk and complex as healthcare. And the reasonable question on people's minds is all this investment worth it? Or is it just AI hype? The outsider optimist will assume that the management consulting predictions, this one by Accenture, will be right on the money, and believe that if healthcare just waits on industry long enough, the value will be realized. But we inside the industry have an opportunity to reflect together on the first few years of the AI revolution and begin to examine the successes and challenges of clinical implementation today, and try to answer for ourselves as a community. Is the promise of AI overvalued in healthcare? Or is our system just not prepared to take advantage of that value yet? Machine learning models have had an impact at a local level, typically using structured EMR data. This work has been mostly about identifying opportunities to close the human cognitive gap. Studies have shown that clinicians make the right decision somewhere between 75 to 90% of the time. And that has been an early opportunity for fairly basic models to augment the simpler cognitive steps of us imperfect humans, like always choosing the right antibiotic for a specific patient and condition. And many of those interventions are working kind of well. Other more complex machine learning models are aimed to speed up or augment complex cognitive steps in clinical care, like identifying a high-risk event more accurately or more earlier than a human can, such as an ED patient with sepsis, or a patient's risk of deterioration in hospital. And some of those pilots have worked well, improving outcomes and saving lives in important conditions in a health system. But it's also important to recognize the barriers for such models to be effective at scale. These types of models have been described as having high sensitivity to domain shifts in local data, shifts in EMRs, local workflows, local patient populations. This recent paper describes how scale impact will depend on systematic local model adaptation through prospective retraining, calibration, validation, bias mitigation, to make sure the model works well, that worked well in location A works well in location B. Not quite starting from scratch, but a lot of work from a data infrastructure and specialized technical skill standpoint. And so in that sense, healthcare is probably overinvested in model development, declaring victory following published pilots, again me, and underinvested in both the data infrastructure and human-centered implementation practices to drive reliable performance at scale. Foundation and representation AI models in healthcare are slightly different. They're trained on unfathomably large amounts of highly standardized modalities, like radiology images or human language, and rely on those universal representations rather than local feature engineering of machine learning. A chest X-ray in Melbourne looks pretty much like a chest X-ray in Sydney. A hospital admission note in New York is written in the same way as a hospital admission note in Los Angeles. So in contrast to machine learning models derived from local idiosyncratic data, they tend to perform more reliably across institutions, demonstrating greater robustness to that domain shift. So resultantly, ambient AI scribes and AI chart summarization tools, and also models that improve diagnostically accuracy of radiologists, are being fast adopted at scale. But why then are most health systems struggling with both machine learning and foundational models at scale? One main reason is the technical infrastructure required for governance, or what I prefer to call AI lifecycle management. As the healthcare community maps out the steps of safe, responsible scale deployment, there's an ever greater appreciation of the importance of an underlying operating system that can continuously link readily available high-quality data to the generation of evidence and practice around AI. I'm not expecting anybody to read this slide, but what I'm trying to convey is the enormity of the task at hand, both in terms of data infrastructure to prepare models locally, and the health intelligence, data engineering, and informatics teams required for this lifecycle management. Many experts increasingly believe that agentic models will offer the greatest impact with AI in healthcare. The primary justification for this optimism is understanding how clinicians work and think. Clinicians often make hundreds of small cognitive steps, decisions, through a single patient's care journey. The machine learning models I reviewed, they're tools that help providers make one or maybe a few decisions in a specific circumstance. Ambient AI and chart summarization tools are really impressive tech, but they have not yet consistently shown the efficiency gains to justify the large vendor contracts. The growing consensus is that agentic AI will guide healthcare teams through a multitude of decisions in a patient care's journey, compressing the time of decisions and improving decision quality, creating much higher value towards organizational goals and justifying those large vendor contracts. Not only will agents need the scale lifecycle model we just saw, but that potentially transformative value will require interaction across multiple data sets, the ones that I just mentioned, to make the best possible decisions for patients. So they'll be across the EMR, across labs, across radiology, operations, genomics. So agents will probably require that costly, consolidated data enterprise warehouse we talked about in the Learning Health System 1.0. So let's just summarize, because that's a lot of information. Machine learning can improve individual decisions and maybe patient outcomes locally, so far. Foundational and representation models scale better, but to date have had marginal impact on health outcomes, the most promising maybe being radiology. To scale responsibly and safely, and to meet the evolving governance and regulatory requirements, both will require huge data infrastructure investments, as well as data engineering and informatics capabilities. The projected future impact of agentic AI on healthcare outcomes is anticipated to hopefully be much greater. expediting and improving multiple decisions across the patient's care journey, but will likely require the interoperable data warehouse so many health services are still trying to achieve. Many of these data challenges are industry agnostic. This recent MIT report notes most companies are preparing for the AI era through a series of strategic steps, including enhancing data quality, addressing legacy silos, and upscaling analytics. So in that sense, healthcare isn't alone. But health systems are at an inflection point. Many hospitals may have a few AI tools in pilot or semi-deployed, but moving beyond pilots demands this centralized lifecycle management and scalable operating models. Approaches that may be working at a really small scale through spreadsheets or informal approvals or retrospective monitoring will likely break down as AI portfolios grow. And are most health systems ready? Over the past 2 years, the World Health Organization conducted an AI for health systems survey across 40 countries. It didn't include Australia, but the answer regarding readiness for AI lifecycle management in a country as buttoned up and well-funded as Switzerland, not even close. Industry experts say it's all about the foundational data stack, and we'll need to spend more on data infrastructure. But they're saying that while trying to sell you expensive data infrastructure projects. So tough to rely entirely on that perspective. In academia, AI researchers have also proposed various operating frameworks to represent what it would take to develop and validate models, as well as maintain centralized, semi-automated lifecycle management at scale. And they will require kind of similar levels of investment. So industry and academia, in this rare and beautiful circumstance, seem to agree. And some of that data infrastructure looks a little to me like the ideal data stack and informatics expertise of the learning health system. So let's look at what data infrastructure would look like for Learning Health System 2.0, the AI era. And hopefully I can convince you that AI maturity is downstream to learning health system maturity. So I hope we can all agree data as a strategic asset should be ultimately leveraged to improve health outcomes. But in 2.0, the AI tech stack will sit on top of an interoperable data foundation, ensuring, one, the ability to perform pre- and post-implementation performance measurement of each AI tool. Two, downstream, the safe, reliable lifecycle management at scale. And then three, measure clinical and operational outcomes associated with each model. The last point is particularly relevant given the costs of the intelligence stack. Learning health system methods might help turn AI ambition into disciplined execution, enabling rapid, relatively low-cost experimentation with real-world measurement. Allow smart organizations to test AI tools locally and learn quickly, and scale only those that demonstrate sustained clinical or operational or financial impact. It's a fail-fast model big tech has been using for decades, but the healthcare version. So in this moment, hospital executives are facing a critical leadership challenge. No longer whether or not to adopt AI, but what front-end investments are needed in what sequence, and how to decide what to scale. Ironically, investing in front-end learning health system infrastructure could be the mechanism for balancing the cost of transformation with the challenge of long-term financial constraints that probably aren't going away anytime soon. In an environment of tight margins and high capital risk, the learning health system could be the knowledge needed to manage AI portfolios, reducing uncertainty, improving patient safety, retiring low-value tools, and directing limited resources towards only those innovations that can justify long-term investment at scale. So going back to architecture, my favorite thing, in this scenario, the house, the health service, the hospital holds the foundational intelligence, elevating the clinicians and leaders within that house to supervise and leverage that intelligence to apply more human-focused judgment, where digital intelligence cannot replace us, for both individual patients and innovating new models of care. Early hospital-level intelligence has begun to emerge over the past few years. Notably, my new home, Royal Melbourne Hospital's Digital Command Centre, has demonstrated early impact on patient flow and promising disruption of siloed clinical decision-making. But no doubt the success of the next plan phase Using AI to supercharge these operational decisions will require meeting some of the challenges we just examined. Okay, so let's put all that in a box. Learning Health System 2.0, still going to be tricky to manifest, still not cheap, but it might be a coherent operating model to ensure AI delivers on improved outcomes. If it can deliver on greater operational efficiency, it might become the first innovation that will ultimately pay for itself. So I want to take a step back a little bit from all this data talk and acknowledge that to date, there is no standard development pathway for digital health innovations. I believe the credit for this elegant comparison belongs to clinician scientist Daniel Kapura. I'm not sure if he's here yet, but this was his work. It contrasts the long-standing scientific consensus of drug development and the relative lack of consensus around preclinical and early translational methods in digital health. Over a decade of experience has informed us that many digital technologies, unlike, for example, switching to a more effective drug, requires careful, thoughtful implementation into clinical workflows if it's ever going to be effective. While consensus methods are still emerging, there is a consensus that the steps of rigorous pre-implementation and pilot implementation testing, followed by subsequent refinements, will greatly improve the likelihood of any digital tool being accepted by end users, and perhaps most importantly, yield the desired impact. It's important to briefly touch on some ideas around what is needed from a people standpoint, again, particularly within a health service or a hospital, for innovation to transform healthcare. If you haven't read this classic HBR review on the traps of innovation, whether you're a student, a non-clinician researcher, or a healthcare leader, I think there's abundance of pearls in there. But I want to summarize 2 key points. Innovation should absolutely not be siloed in a single transformation vertical. Drawing again on inspiration from my new institution, the entire leadership team is developing a shared philosophy on how both innovation can meaningfully impact their domain and the type of data transformation that can support it. Whether that means intentionally building trust within the workforce, rethinking how work is done and upskilling teams, or selectively adopting new technologies to deliver measurable value. But also the most durable and impactful innovation emerges when frontline teams and domain experts are empowered to identify problems, test solutions, and celebrate their learning. Whether the innovation works or not, this will ensure change is grounded in practice, not imposed from above. And I think as a scientific community, we're all really guilty of celebrating victories, things that we measured that showed success. And I would love for us to celebrate more falling in love with the problem, doing rigorous science, even if what we find out it doesn't work. That's amazing work. To realize that we shouldn't scale is a huge responsible piece of our work as scientists. You know, I'm going to go off script for a second. You know, I was flying here with my wife. It was over Christmas Day. So we got on the plane Christmas Eve, and then we arrived in Australia on the 26th. So we had Christmas on the flight, and I gave her a pair of pink pajamas. And she said to me, you did all this science in New York. Like, what do you think your greatest achievement was? And I thought about all the science I had done, and I would love to say that I had found technology that transformed healthcare. But the truth is, the greatest accomplishment that I can bring to Australia is a deeper understanding of the challenges that are in front of us. All the problems I face with my science, understanding the shape of that will help us navigate. So presenting what you found didn't work is valuable. It enhances our knowledge, enables us to forge together to find solutions that will work. So please reflect on that, junior researchers. And it's on us as senior leaders to open the doors for you to present that type of work. Believing in the learning health system model as strongly as I do, I also believe the most effective digital transformation emerges from close partnerships between health services and academia. As an analogy, healthcare has long embraced the power of combining doctors with nurses and allied health, knowing that the patient benefits the most when we work together. Transformation should model that excellence, I believe, allowing real-world implementation capability with deep data science, informatics, and evaluation expertise, around a clinical problem. These power teams can accelerate innovations from problem to impact, ensuring the development processes is both scientifically rigorous and operationally viable in the real world. So for the ambitious young non-clinical researchers in the audience, reach out to one of these amazing teams, reach out to Kit, reach out to me, to explore how you can thrive in this model. From my own lived experience, you will not look back. And lastly, just a quick nod to the very human work in front of us to prepare for agentic AI's exciting potential. Adopting any new worker in the workforce requires us to rethink how that new team is going to play well together. In the case of agents, it'll be to understand how they can help the team do the same tasks, but more efficiently and with more consistently high quality. This work, led by the University of Melbourne's Professor Harriet Hiscock, the WeCare project, is starting to study how hospital staff spend their clinical time. They're using modeling to test and then recommend safer, more standardized and efficient ways of organizing ward work, perhaps paving the way for the integration of AI-assisted clinical care. The message here is that as our dreams for digital transformation unfortunately become increasingly more complex, that calls on us to lead this transformation in a deeply human way. And understanding our people and the work they do is a great step in the right direction. Thank you for listening.